Hello there, my highly valued and treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arua, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector workers, the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for a high-impact pharmacotherapy services in your line of duty. So I would like to urge you to sit back and spare me part of your very precious time as I share some tips with you. Welcome to part 24 of our pharmacotherapy MCQ series. So our first question reads, S.B.B. is a 56-year-old female with a history of supraventricular tachycardia who presents to the A&E with complaints of palpitations. Her ECG demonstrates SVT with a rate of 210 beats per minute. She is awake and alert. She appropriately answers questions. Her other vitals remain normal. The team is preparing to administer adenosine to this dear lady. Which of the doses listed below would be the most ideal for this patient right now? Would it be 6 milligrams administered via IV push, or would it be the same dose via slow IV infusion, or would it be the same dose administered intramuscularly, or is adenosine contraindicated, and would electrical cardioversion be the preferred intervention at the moment? I'll give you 10 seconds to choose the correct answer. So A it is. This patient should receive 6 milligrams of adenosine via IV push. And that is the correct starting dose for this particular drug in this particular indication. And we know that adenosine is metabolized very rapidly, in 10 seconds to be precise, and must therefore be pushed IV very rapidly, not slowly followed by it should then be followed by sufficient saline flush to ensure that dose is delivered to the heart before it is metabolized. Otherwise, it would not serve its purpose. Electrocardioversion is necessary when the patients are considered to be unstable. Our patient here is fairly stable, conscious, and is able to respond to questions. And unstable usually implies the target organs are damaged, and or there is hemodynamic instability, which we do not see in this particular case. If no clinical effect is observed after the first IV push, subsequent administration may be delivered up to 2 additional times at higher doses of 12 milligrams via IV push. Now, for ease of administration, adenosine may be diluted with 20 to 30 ml saline flush. Now, this strategy allows for both the medication and the flush to be administered simultaneously. An important factor in resource-limited settings or during peak hours when we do not have enough personnel to intervene in this particular emergency. So that was just a by the way. The correct answer is A. Let's move to the next question. A white HIV-infected male patient presents to the clinic for hyperlipidemia management. He has a past medical history significant for peripheral neuropathy, lipodystrophy, hypertension, and he abuses tobacco. He is currently taking lamivudine, co-formulated with abacavir. He takes a tablet a day. He also takes fibrates at a dose of 600 milligrams once daily in the evening, and he takes 25 milligrams of amitriptyline at bedtime. He's also on Lisinopril 20 milligrams, which he takes orally once a day. Now, his current fasting labs include a CD4 of 352 cells per mm. His viral load is below 50 copies per ml. The potassium level is 4.5, on the higher side of normal. He has a creatinine of 0.9, glucose of 109, AST to ALT of 35 and 31 respectively. The TC is 253, the TG is 291, his LDL cholesterol is 165, and the HDL is 31. His 10-year atherosclerotic cardiovascular disease risk score is 20%, and he has a metabolic syndrome as per the AHA/NHLBI criteria. So my question to you is, which of the statements below would this patient be a candidate to receive that we would offer him the greatest reduction in lipids but wouldn't compromise safety or viral control? Would it be extended release niacin at a dose of 500 milligrams at night, or would it be 40 milligrams of Simvastatin administered orally at night, or would it be 10 milligrams of pravastatin administered at a dose of 10 milligrams at night, or would you opt for Fenofibrate 145 milligrams administered once daily? I'll give you 10 seconds to choose the correct answer. So alternative B would be the correct option. Now, based on this patient's history, risk factors, and criteria for metabolic syndrome, the primary target is LDL lowering, for which the best option, statins, would be a good choice. Statins would be superior, so Fenofibrate automatically falls out. Now, his TGs are elevated, but they have not exceeded 400 milligrams per deciliter, and treating them with Fenofibrate hasn't been shown to reduce mortality in any population. So I would not favor D in this particular case. Now, although Simvastatin is contraindicated in HIV positive patients receiving PI-based heart regimens, it isn't contraindicated in NNRTI-based regimens, such as this one, who is receiving fibrates alongside lamivudine and abacavir. It is, or it can be used with fibrates because fibrates is a CYP3A4 inducer. It slightly reduces the Simvastatin concentration by approximately 58%, but that does not significantly diminish the efficacy of Simvastatin. Now, fibrates reduces pravastatin's area under the curve by a whole 40%, and that makes it less suitable than Simvastatin. The magnitude of the drug-drug interaction with pravastatin is greater. Now, niacin wouldn't be superior to simvastatin in lowering LDL, and Fenofibrate is effective and safe in HIV-infected patients on heart, but it isn't going to be the primary target when it comes to reducing LDL, which is our focus in this particular question. So all those sum up to make alternative B our correct option. Let's move to the next question, which reads, you are doing an initial assessment for a 72-year-old Hispanic patient with stage C heart failure with a left ventricular ejection fraction of 30%. You note he isn't on any beta blocker, and the reason for that is unknown. Maybe it was a lapse in the part of the team that is managing him, and he denies current HF, heart failure symptoms, and he is classified, in your opinion, as euvolemic. He denies any history of adverse events with any medications. Now, the formulary beta blockers stocked in your hospital pharmacy include atenolol, bisoprolol, labetalol, metoprolol tartrate, and propranolol. So which from these drugs on your formulary would be the best choice for this particular patient? Would it be propranolol? Would it be bisoprolol? Would it be labetalol or metoprolol tartrate? I'll give you 10 seconds to choose the correct answer. So bisoprolol it is. So on this formulary, in my opinion, bisoprolol is the only one with data supporting its use in heart failure patients with survival benefits. Metoprolol tartrate, to be specific, does not have any data supporting its use in heart failure patients. This is a short-acting, twice-daily form of metoprolol which lacks favorable heart failure data. Now, the succinate, the metoprolol succinate extended release form can be used in heart failure patients with good clinical outcomes. Carvedilol is the other heart failure beta blocker with data to support its use. Let's move to the next question. A 60-year-old white female patient takes amlodipine, carvedilol, lisinopril, and hydralazine for the management of her hypertension. She presents to the clinic complaining of a dry, non-productive cough. Other causes of the cough are ruled out after a thorough physical examination, and you strongly attribute this dry, non-productive cough to one of the antihypertensives the patient is taking currently. So which, in your opinion, of the antihypertensives listed below would be the most likely cause of this dry, irritating, and productive cough? Is it carvedilol, amlodipine, lisinopril, or hydralazine? I'll give you 10 seconds to choose the most probable cause of the dry cough. So lisinopril is the most likely culprit. Now, this kind of cough is a common side effect of the angiotensin converting enzyme inhibitors as a class, and lisinopril happens to be one of them in this list. And that cough occurs due to the inhibition of bradykinin breakdown via inhibition of ACE. Now, that leads to bradykinin accumulating in the lung parenchyma, thereby causing irritation to the tissue, resulting in that dry cough. Discontinuation of ACE inhibitor therapy should lead to the resolution of such coughs. Now, cross-sensitivity with the ARBs is minimal, and therefore an ARB can be appropriate to consider as an alternative if the patient needs to continue on renin-angiotensin-aldosterone system blockade as a mode of treatment. Other causes of cough such as this should be considered in the differential, just as a by the way. Let's move to the next question. Mr. ATO is a 36-year-old male patient who recently received a drug-eluting stent to his left anterior descending coronary artery during a PCI intervention. Dual antiplatelet therapy, so-called DAPT, was initiated thereafter with aspirin and ticagrelor. For how long should Mr. ATO take this dual antiplatelet therapy? Should it go on for half a year? Should it go on for 18 months? Should he take them for a whole year? Or should it prefer a month? I'll give you 10 seconds to choose the correct answer. This should go on for at least a year. C is the correct answer. DAPT in patients with drug-eluting stents is recommended for at least 1 year, 12 months, with evaluation for long-term therapy based on the unstable angina or NSTEMI forecast update. 1 month of DAPT is recommended as a minimum, and I'll underscore the word minimum, for a bare metal stent, not a drug-eluting stent. However, update authors recommend 12 months of DAPT for patients with bare metal stents if, and I repeat, if the benefits outweigh the risks. So that's just a by the way. Let's move to the next question. HBB is newly classified as stage C heart failure and is experiencing volume overload symptoms, which include edema and increased shortness of breath. You desire to add furosemide therapy to the regimen he is on currently. Which predictable effect listed below would be expected in HBB with chronic furosemide therapy? Would it lead to hyperkalemia? Would it lead to hyperuricemia? Or would it cause hypernatremia? Or would it be hypercalcemia? I'll give you 10 seconds to choose the correct answer. Hyperuricemia it is. Furosemide, a loop diuretic, blocks the sodium-potassium chloride symporter, which is a membrane transporter that transports those three ions from the nephron lumen to the interstitial space simultaneously. And that results in a net loss of sodium, potassium, and calcium via electrical gradient differences and excretion of calcium and magnesium as well. During acute administration, uric acid excretion is actually increased. However, chronic administration causes a reduction in uric acid excretion, possibly due to enhanced proximal tubal reabsorption, and this is possibly in part due to dehydration that ensues, or due to competition at the secretory mechanism of the proximal tubule between the loop diuretic and the uric acid. While mild chronic hyperuricemia is common with loop diuretic therapy, which can be fairly asymptomatic, painful gout episodes are also possible with chronic administration. So that's just by the way. Let's move to the next question. So Mr. ASV, a 54-year-old Hispanic man, reports for his clinic appointment for the management of his elevated BP. His BP 60 days ago was 157 systolic, 97 diastolic, upon which he was advised to begin therapeutic lifestyle changes. He has no significant past medical history and takes no medication currently. When you weigh him today, you establish he has successfully shed 5 pounds during the past 60 days, and he currently weighs 190 pounds. His today's blood pressure readings are 147 systolic, 92 diastolic, and he has a pulse of 63. His pertinent labs includes a serum creatinine of 1.2. Potassium levels are 5.1 milliequivalents per liter. So, which of the recommendations below would be the best to propose to ASV? Would you advise him to achieve a blood pressure goal below 150/80, and would you start him on diltiazem? Or would you propose a goal of below 130/80 and initiate lisinopril? Or would you propose a goal of below 140/90 and start amlodipine? Or would you opt for a goal of below 130/80 and start hydrochlorothiazide? I'll give you 10 seconds to choose the correct answer. So I would opt for D. I would set a goal of below 130 systolic, 80 diastolic, and propose he begins taking hydrochlorothiazide in the morning. Now, Mr. ASV is diagnosed with hypertension, therefore initial monotherapy would be appropriate according to guidelines out there. His goal BP, given no compelling indications such as diabetes mellitus or chronic kidney disease, should be 130 systolic/80 diastolic. His baseline heart rate is 63. Therefore, diltiazem in option A wouldn't be appropriate choice given its rate lowering properties. It is negatively chronotropic. And potassium in this particular case, according to the pertinent labs, is on the upper end of normal at 5.1 milliequivalents per liter, which makes lisinopril less desirable given its ability to raise potassium levels. Amlodipine would be, in my opinion, a reasonable choice, but the goal BP for answer C, which is 140/90, is incorrect. Now this leaves me with hydrochlorothiazide as the most appropriate choice, partly by the process of elimination. It will, however, lower the potassium levels, and therefore AVS may benefit from both the antihypertensive and the potassium lowering effects of hydrochlorothiazide. So it would be the best choice amongst those drugs, in my opinion. Let's move to the next slide. Select the most accurate statement regarding the P2Y12 receptor antagonists. Is it clopidogrel, which is Plavix, only undergoes phase 2 metabolism to get activated and is a reversible inhibitor of the P2Y12 ADP receptor? Or is it patients who have received ticagrelor pyrulenta may not have to wait 5 days if cabbage is needed due to its reversible inhibition of the P2Y12 ADP receptor? Or is it ticlopidin, which is ticlid, only needs to be dosed once daily but requires monitoring of the CBC due to a risk of agranulocytosis? Or is it finally prasugrel effiant is metabolized by CYP3A4 to an inactive metabolite and causes reversible inhibition of the P2Y12 ADP receptor? I'll give you 10 seconds to choose the correct answer. So answer B is correct. Ticagrelor is a reversible P2Y12 ADP receptor blocker and thus may not cause the same delays that are sometimes required when patients need to undergo cabbage whilst they are on clopidogrel or prasugrel. Missing doses could theoretically increase the risk of rethrombosis in patients who have received coronary stents before. Now, clopidogrel is an irreversible antagonist of P2Y12 ADP receptors and that is not in line with the answer A. Now, it requires 2 steps of activation by phase 1 metabolic pathways, not by phase 2 or conjugation pathways. So that makes answer A wrong. And clopidogrel is a prodrug which must be metabolized in order to exert any beneficial antiplatelet effect. So I would disagree totally with answer A. And ticlopidin should be dosed twice daily, not once daily as in answer C. Because of its ability to cause agranulocytosis, patients need periodic CBC monitoring, and that makes it less desirable than the other agents. But because of the twice daily dosing, answer C is wrong. And prasugrel is a product which requires metabolism via the CYP3A4 to an active metabolite in order to exert any relevant antithrombotic effect. So the word inactive makes option D unsuitable or incorrect. I would settle for B in this particular question. Let's move to the next slide. Mr. SOJ is an 83-year-old Kenyan man who presents with the Aga Khan University Hospital Cardiac Clinic for hypertension management. His home BP readings for the past 3 days are as follows: 174/68, 168/70, and 172/66. Today, his BP readings are 172 systolic, 72 diastolic, and after repeating, you record 166 systolic and 68 diastolic. He is currently on Lisinopril and hydrochlorothiazide. So mark that is on 2 drugs from 2 different classes. He reports no complaints with his medications and his labs are within normal limits. How would you best describe his category of hypertension? Is this resistant hypertension? Is it hypertensive urgency, hypertensive emergency, or isolated systolic hypertension? I'll give you 10 seconds to choose the correct answer. So this is a form of isolated systolic hypertension. By definition, since the systolic BP is elevated above 130 meters of mercury, whereas the diastolic BP is within acceptable limits, that is below 80 mmHg. Now answer B, resistant hypertension is defined as poor blood control when a patient is on 3 or more antihypertensive agents from different classes, with one of the classes preferably being a diuretic. Now a patient is on a diuretic and a second drug, so he doesn't qualify. He's not yet on 3 medications, so that makes answer B incorrect, and C as well. He doesn't meet the criteria for hypertensive urgency or emergency, which should be a systolic of above or equal to 180 and a diastolic of above or equal to 110 respectively. And we don't have any incidences of end or target organ damage in this patient's case, so that disqualifies any classification as hypertensive urgency or emergency. We should have had a mention of stroke, MI, loss of vision, AKI, and so on and so forth for him to qualify for either B or C. There is no evidence or mention of target organ damage at all. So I would settle for isolated systolic hypertension as the best description for this gentleman. Let's move to the next question. ASB is a 65-year-old white man who has been experiencing 2 to 3 episodes of chest pain on a daily basis on exertion, and he is diagnosed with chronic stable angina at your cardiology clinic. However, he isn't a candidate for PCI or CABG according to your clinical team at the clinic. The team plans to optimize his medical management. He has a past medical history of coronary artery disease. He's had 2 MIs. The first one was 5 years ago. The second was a year ago. He's hypertensive. He has hyperlipidemia, type 2 diabetes. And he's currently on prophylactic aspirin, low dose aspirin at 81 milligrams once a day, carvedilol 25 milligrams twice daily orally, isosorbide dinitrate 20 milligrams every 8 hours orally, and Lisinopril 40 milligrams once a day orally, together with rosuvastatin at a dose of 40 milligrams taken at bedtime, high intensity statin. He also administers the insulin 70/30 at a dose of 40 units in the morning and 25 units in the evening subcutaneously. His blood pressure at the moment is 142 systolic, 82 diastolic, with a heart rate of 56. Now you give him some time and repeat the measurements, and it is 140 systolic and 86 diastolic, with a heart rate of slightly lower value of 52. Now about his labs, the Chem7, lipid panel, and CBC are within normal limits, and he established he has an A1C of 6.9%. So my question to you is, which of the listed pharmacologic options would be the best or the most appropriate to address this gentleman's angina symptoms? Would it be increase the isosorbide dinitrate dose to 40 milligrams thrice daily and add amlodipine at a dose of 2.5 milligrams orally once a day? Or would you increase the carvedilol dose to 50 milligrams twice daily and add verapamil extended release at a dose of 180 milligrams orally once a day? Or would you increase the carvedilol dose to 50 milligrams twice daily and add amlodipine 2.5 milligrams orally once a day? Or would you increase the isosorbide dinitrate dose to 40 milligrams thrice daily and add verapamil extended release at a dose of 180 milligrams once daily orally? I'll give you 10 seconds to choose the correct answer. So I would settle for A. I would up the isosorbide dinitrate dose to 40 milligrams every 8 hours and introduce low dose amlodipine at a dose of 2.5 milligrams orally once daily. Maximizing the existing anti-anginal therapy and or improving myocardial oxygen demand through improved hemodynamics, that is BP and HR improvement, are the key options to improving angina symptoms in any patient like this gentleman. His BP is slightly higher than the preferred goal for his category. He should actually be at less than 140 over 90. Yeah, because he's a patient who is over 60 and he has type 2 diabetes. So according to the J and C, he should have a target of below 140 over 90. He's not yet there. Increasing or adding further antihypertensive therapy would be reasonable and a preferred way out. Now, of the listed options, increasing carvedilol and adding verapamil would both further lower his heart rate. He's already at 56, if I remember, which is already well controlled, and thus not preferred options, making answers B and C incorrect. Now, adding amlodipine, a dihydropyridine calcium channel blocker, would lower his blood pressure and dilate the coronary arteries, and that would provide improvement in angina without further lowering his heart rate. Now, increasing isosorbide dinitrate and amlodipine is therefore the most reasonable option in my opinion, so I would settle for A. Let's move to the next question. Which of the statements below is correct regarding enoxaparin use? Is it inhibits more factor 10A than factor 2A? Or is it requires the presence of antithrombin in order to function? Or is it can be initially administered as a single IV dose for patients with STEMI? Or finally, is it dose reductions are needed once the creatinine clearance is less than 45 ml per minute? I'll give you 10 seconds to choose the correct answer. So answers A, B, and C are all correct. Enoxaparin is a low molecular weight heparin which requires the presence of antithrombin in order to function normally against the clotting factors. It inhibits factor 10A at a greater degree than factor 2A, and the ratio is usually 3:1. The inhibition of factor 10A is 3 times greater than that of factor 2A. It is the only low molecular weight heparin with FDA approval or approved dosing for STEMI, and that includes an initial IV bolus at a dose of 30 milligrams IV push start, that is once. It doesn't require renal dosing until the creatinine clearance falls below, and I underscore 30, not 45 like in our alternative D, 30 ml per minute. Now, once the creatinine clearance falls below 30, the subcutaneous dosing changes from 1 milligram per kilo subcutaneously twice daily to 1 milligram per kilo subcutaneously once daily. And it is likely to cause heat, just for your information, as compared to the unfractionated heparin. Now, the other cousin, dalteparin, is also known to be a low molecular weight heparin, but it doesn't have renal dose adjustment, and IV boluses are not recommended for treatment in NSTEMI. So that's the difference between dalteparin use and enoxaparin use. Just by the way, for your information. Let's move to the next question, which reads, which of the potential side effects listed below applies to the use of thiazide diuretics? Is it hyperkalemia, hyperuricemia, hypoglycemia, or ototoxicity? I'll give you 10 seconds to choose the correct answer. So hyperuricemia it is. Thiazide diuretics like hydrochlorothiazide inhibit the secretion of uric acid into the proximal tubule of the nephron by inhibiting the organic ion transporter. They cause hypokalemia, not hyperkalemia, and have been associated with hyperglycemia, not hypoglycemia. So that makes options A and B incorrect. Now, ototoxicity happens to be a side effect of loop diuretics and not thiazide diuretics like hydrochlorothiazide. So that leaves us with answer B as the correct answer. Let's move to the next question. Which of the following fibrates used in the management of hypertriglyceridemia are known to cause drug-drug interactions with many statins? Is it Fenofibrate, Ezetimibe, Gemfibrozil, or Simvastatin? I'll give you 10 seconds to choose the correct answer. So Gemfibrozil it is. Gemfibrozil is the fibrate primarily known to inhibit the metabolism and elimination of statins partially through its inhibition of the glucuronidation process via UGT1A1 and 1A3 enzymes. While most statins are metabolized by the cytochrome P450, all statins also undergo some degree of glucuronidation in the body for the purposes of enhancing elimination into the bile and or urine. Statins also utilize many influx and efflux transporters for their distribution throughout the body. Now, inhibition of any one or combination of these pathways can result in the accumulation of statins in the body, thereby putting the patient's life at risk of developing what we call rhabdomyolysis, which can really harm the kidneys, and or hepatotoxicity. Now, neither fibrates are inhibitors of cytochrome P450 enzymes used by statins. And we know that Gemfibrozil can inhibit the glucuronidation and some transporters that we've mentioned that they rely upon. So Gemfibrozil and not Fenofibrate is known to inhibit glucuronidation of statins and thus to put them at an increased risk of myositis and hepatocellular damage. So Gemfibrozil would be our best option when you put all those facts together, in my opinion. Let's move to the next question, which reads, Mr. WKO is a 77-year-old white man with chronic stable angina who is referred to your cardiology clinic for management. He isn't taking any anti-angina medications at the moment. Now, after a thorough medical examination or evaluation and interviewing him The cardiologist at the clinic opts to start pharmacologic therapy to improve his overall myocardial oxygen demand. So my question to you is, which of the medications listed below would be the most appropriate to achieve the goal of decreasing heart rate and contractility in this particular patient, Mr. WKO? Would it be atenolol, lisinopril, amlodipine, or isosorbide mononitrate? I'll give you 10 seconds to choose the correct answer. So I would settle for atenolol. Now, management of angina is about maximizing oxygen delivery or supply and minimizing oxygen utilization, which we call demand. The three key components of oxygen demand are heart rate, contractility, and intramyocardial wall tension. Prescribing a beta blocker, such as atenolol, is the only one of the above options that would affect oxygen utilization by acting on the beta-1 receptor in the heart, leading to a decrease in the heart rate and contractility. Amlodipine, which is a dihydropyridine calcium channel blocker, improves angina by decreasing systemic vascular resistance and vasodilation of the coronary arteries. Now, for lisinopril, which is an ACE inhibitor, primarily improves angina through its BP lowering properties. Isosorbide mononitrate indirectly reduces the myocardial wall tension through venodilation, both systemically and within the coronary circulation. So of all the three, atenolol would be my best choice because of the explanations I've offered on how they act to influence angina symptoms. So let's move to the next question. Which of the drugs listed below is the least effective in controlling heart rate during exercise in a patient with atrial fibrillation? Is it digoxin, metoprolol, verapamil, or diltiazem? I'll give you 10 seconds to choose the correct option from that list. So digoxin it is. Now, digoxin only controls heart rate at rest and not during physical activity. Mark that. It reduces pulse through a reduction in the conduction velocity of cardiac action potential through the AV nodal cells. This is accomplished through the digoxin's inhibition of the sodium potassium ATPase in vagoafferent fibers to directly enhance sensitivity of the cardiac baroreceptors, which results in a reduction in sympathetic outflow from the central nervous system, thus reducing the chronotropic effect on the nodal cells. That reduces pulse, which is why it can be used in rate control. That makes alternative A the correct answer. Let's move to the next slide. Which of the monitoring parameters listed below don't apply to amiodarone use in patients? Is it lipases every half a year, 6 months? Is it an ECG annually? Is it the thyroid function test every 6 months? Or is it a chest x-ray annually? I'll give you 10 seconds to choose the correct answer. It is. Monitoring pancreatic function isn't indicated when using amiodarone. Now, an ECG or an EKG is performed to monitor for QT prolongation. So that makes answer B incorrect. You need to monitor. Thyroid function tests are performed to monitor hyper or hypothyroidism. Then a chest x-ray is usually performed to monitor pulmonary toxicity. Just rule out that it's not happening as you use the amiodarone. Now, the above monitoring parameters vary in frequency based on development of symptoms, or they can be done at least annually, even when the symptoms do not occur, while on chronic amiodarone therapy as part of routine outpatient management, just to ensure the patients are safe when using amiodarone long term. So let's move to the next slide. A 54-year-old Kenyan man presents with a past medical history of uncontrolled hypertension, MI, with 2 drug-eluting stent placements 2 years ago. He also has hyperlipidemia and he uses tobacco. He has a history of 25 pack years, and he has a 10-year atherosclerotic cardiovascular disease risk score of 12%. His chief complaint at the clinic is dyspnea while walking down the block to the corner store to do his shopping, which has lasted 14 days. And he states that his legs have been swelling more over the last 7 days, and the swelling increases as the day progresses or goes by. He is currently on 40 milligrams of Atorvastatin at night. That is the lower end of the high intensity statin therapy. Prophylactically, he takes 81 milligrams of aspirin once a day. He's also on metoprolol tartrate, 25 milligrams twice a day, and he takes Lisinopril, 20 milligrams orally once a day as well. Now, his echocardiogram results show an ejection fraction less than 40%, and he is diagnosed with HFrEF, heart failure with the reduced ejection fraction. Now, his blood pressure is 142 systolic, 65 diastolic, and he has a heart rate of 73, and his respiratory rate is 16 breaths per minute. His pertinent labs include sodium of 142, potassium of 4.5, serum creatinine of 1.1, an estimated GFR of above 60, and a BNP of 240. So my question to you is, which of the recommendations below would be the best for this gentleman for his treatment moving forward from now onwards? Would you increase the lisinopril dose and initiate spironolactone? Would you increase the metoprolol tartrate dose and add valsartan succinylcholine? Would you increase the metoprolol tartrate and initiate carvedilol? Or would you discontinue amlodipine and initiate verapamil? I'll give you 10 seconds to choose the correct answer. So I would discontinue metoprolol tartrate and initiate carvedilol. Remember, in the heart failure patients, the preferable choice is metoprolol succinate, not tartrate. Now, guideline-directed medical therapy, which we abbreviate as GDMT, for heart failure includes initiation of an ACE inhibitor or an ARB and a beta blocker. Now, beta blockers that have been shown to have survival benefits are metoprolol succinate, carvedilol, and bisoprolol. And the patient is already on an ACE inhibitor, which is lisinopril. Therefore, it wouldn't be prudent or appropriate to add another ARB neprilysin inhibitor combination at this time, and that makes alternative B wrong. Increasing metoprolol tartrate doesn't or wouldn't be appropriate since it's an inappropriate beta blocker for the medication for the treatment of heart failure patients. It's not evidence-based at all. Now, target lisinopril doses are usually 20 to 40 milligrams once a day. Now, since the patient is already on 20 milligrams of lisinopril, it wouldn't be the most appropriate option to increase it beyond 20. 20 would just be fine. Now, spironolactone has been shown to have survival benefit in heart failure patients. However, he is currently not on GDMT, so I do not see any diuretic thiazide, high thiazide or loop diuretic there. So spironolactone wouldn't be the most appropriate option. It might, however, be beneficial to introduce a loop diuretic before a potassium sparing diuretic, especially since this gentleman's potassium is on the upper end of the normal range. Now, verapamil wouldn't be a good choice either. It should not be used in heart failure patients like him, especially bearing in mind that his heart rate may be on the lower side. If I remember well, the rate, okay, his heart rate was not very low, but verapamil would not be a good choice for heart failure patient like this particular gentleman. So I would opt to go for alternative C, discontinue metoprolol tartrate, initiate carvedilol, which is backed by evidence. It has benefits in heart failure patients. Let's move to the next question, which reads, Mr. SHL is a 79-year-old white patient who presents to your A&E complaining of nausea, vomiting, blurry or fuzzy vision, which he describes as, in his own words, more yellow than usual. His spouse adds that he seemed more confused, in her words, in the last few days, which is the major reason she opted to bring him to your A&E. Now, the gentleman denies recent illness and claims all have been doing is working out in the garden. So he's been doing some bit of exercise, and physical work. Now, his past medical history is an MI, he has coronary artery disease with an MI, his heart failure, but his left ventricular ejection fraction is not known, and he has dyslipidemia. Currently, he takes 5 milligrams of ramipril once a day. He's on metoprolol succinate at a dose of 25 milligrams once a day. He also takes bumetanide 2 milligrams once daily in the morning, and he supplements his potassium with the slow K tablets. Takes an equivalent of 10 milliequivalents orally once a day. He's also on digoxin at a dose of 0.25 milligrams. Underline that in relation to his age, takes 1 tablet once daily. Then pravastatin 10 milligrams at bedtime, and prophylactically he takes aspirin at a dose of 81 milligrams once daily. Now, his vitals are within normal limits except for his heart rate, which is low, 52. And among his pertinent labs, but sodium stands at 138, potassium is 4.8, BUN is 55, serum creatinine is 1.7, and his blood glucose levels are 94 milligrams per deciliter. Now, based on this information, what could be the cause of Mr. SHL's problem? Is it the potassium chloride, the digoxin, the bumetanide, or the pravastatin? I'll give you 10 seconds to choose the correct answer. Digoxin it is. Now, these symptoms are consistent with digoxin toxicity. He appears to be pre-renal given his BUN to serum creatinine ratio, possibly due to working out in the garden and or due to the diuretic therapy, which may have increased his digoxin level. The fact that he's above 70 years old, 70 years, remember he's 79 or so, and the recommended dose of digoxin should not exceed 0.125 in this particular age group makes me suspect this digoxin toxicity. He's getting a dose that is double that which he should be getting. So even the dosing here is an issue. Now, it's very important to remember that patients' renal function will decline with age. This gentleman is aging, which is relevant given that digoxin is primarily eliminated renally by the kidneys. Now, digoxin has a narrow therapeutic index, and when there is renal impairment, the risk of toxicity is greater. Now, the non-cardiac symptoms of toxicity in the case of digoxin include loss of appetite, abdominal pain, nausea, neuropsychiatric manifestations, visual disturbances, among others. So all these sum up to make me biased towards digoxin as the cause of this gentleman's condition. So I would settle for B as the correct answer. Let's move to the next question, which reads LMM. A patient with stable angina has received a prescription for nitroglycerin sublingual tablets. So you are the pharmacist dispensing at the counter. Which of the listed storage recommendations is correct for this particular drug? Would you advise the patient to refrigerate any unopened bottles, and that once he has opened the bottle, he should store the tablets at room temperature in the original glass container? Or would you advise him to store unopened bottles at room temperature, and once he begins taking his tablets, he should store at room temperature in any container convenient for him to access the tablet's PRN? Or would you advise him to store any unopened bottles at room temperature, and once opened, to store at room temperature in the original container? Or would you advise him to refrigerate any unopened bottles, and once they are opened, to store them at room temperature in any container convenient to him for easy access? I'll give you 10 seconds to choose the correct answer. So in my opinion, C would be the correct answer. Now, these nitroglycerin tablets should be stored at room temperature at all times in the original bottles to protect them from both light and moisture, to avoid shortening the half-life. So they should be kept tightly capped in a glass container to prevent loss of potency. So that makes answer C our best option. Let's move to the next slide, which reads, which of the following antiarrhythmic drugs is recommended to maintain normal sinus rhythm in patients with atrial fibrillation and who is hypertensive with substantial left ventricular hypertrophy? Is it amiodarone, dofetilide, dronedarone, or propafenone? I'll give you 10 seconds to choose the correct answer. Amiodarone it is. Amiodarone is the drug of choice in patients with atrial fibrillation, hypertension, and with substantial left ventricular hypertrophy, which can be classified as a structural heart disease. Dofetilide, propafenone, and dronedarone aren't recommended in patients with structural heart disease at all, so that makes them unsuitable options. Let's move to the next slide, which reads, DAK is a 52-year-old black male patient who has received in the past a drug-eluting stent via PCI to the left anterior descending artery, what we call LAD in your cath lab. Now he asks you the benefit of a drug-eluting stent or the edge that it has over bare metal stent, because he notices the two costs are different. So which of the responses below would best answer this gentleman's query? Would you tell him the drug-eluting stent better prevents restenosis than the bare metal stent? Or would you tell him it inhibits thrombosis, or it reduces heart failure, or it decreases arrhythmias? I'll give you 10 seconds to choose the correct answer. So I would opt for answer A. It better prevents restenosis. Now, a drug-eluting stent is more beneficial in preventing restenosis, and it is superior at this to the bare metal stents. Now, antiplatelet medications inhibit stent thrombosis, so answer B is wrong. Now, the stent in general could theoretically reduce the risk of future heart failure or arrhythm development, as coronary artery disease is a common etiology in both of those two diseases. And the bottom line here is the pathophysiologic correction seen with drug-eluting stents is by preventing restenosis. So that gives answer A an edge over the three other answers. Now, ladies and gentlemen, I highly appreciate the fact that you made time and sacrifice to view this video and to listen to me. If this video helped you in any way, I would like to remind you to give it a thumbs up, to like it, and to share it as widely as you can. And I would like to remind you to subscribe to my YouTube channel if you haven't yet done so. I would like to promise you from the bottom of my heart that the best is yet to come. Thank you for listening and for watching, and I hope to interact with you in part 25 of our pharmacotherapy MCQ series. Thank you.